Welcome to the NHMS Expert Interview Series, Selling to the NHS. Conversations with the people who know NHS procurement best.
Hello, everybody, and welcome to this week's episode of Selling to the NHS. My name is Barry Shrier, and each week we set out to bring to you experts who are involved in the NHS, the National Health System here in the United Kingdom, and people who have expertise in how to do business with the NHS, how NHS organizations procure things, what's involved in procurement, and a lot of the leadership topics and issues involved in both procurement and the direction that the NHS is going. So this week, I'm extremely proud and delighted to introduce you to my friend Andrew Stradling. Hi, Andrew. Hello, how are you?
Hi, Barry. Good to talk to you again.
Yeah, thank you so much for joining us. We're grateful for your time and looking forward to this conversation. So to begin with, Andrew, if it's okay, we'd just like to invite you to introduce yourself rather than me talking about your background in a boring monologue voice, reading your LinkedIn profile. So we'd really love to hear a little bit about you and your background, please.
Sure. So I'm Chief Medical Officer for NHS London Procurement Partnership, and I think that's mostly what we'll be talking about today.
Yes.
I'm also Interim Chief Medical Officer for a health and care partnership outside of London. I'm Medical Director of the National Council for the Healthcare Supply Association, and I'm an Associate Professor at UCL for their Global Business School for Health.
Excellent. And you began as an emergency medicine doctor, is that correct?
Yes, I've been an emergency medicine consultant since 2008.
Yeah.
And then sort of progressed through, I guess, local leadership roles and then taking on regional roles. I've done some national and overseas advisory positions and have found myself in these rather exciting and privileged positions that I'm in now.
Absolutely. I do remember an interesting conversation we had a little while back about your career in emergency medicine. And what was it? The kind of training, the grounding, the expertise that one develops in that area, probably way beyond stitching people back together. And I thought that was quite interesting, your comments about that.
Yeah, I think what I see within my colleagues in emergency medicine is whether it's innate or learnt ability to manage a lot of competing demands,
Yes.
to understand in a complex environment what the important things are, and to manage a lot of a complex multidisciplinary team,
Yes.
a lot of different people, and patients when I think they are among the patients who are most frightened, vulnerable at that time, people who are experiencing a need for emergency care. Nobody expects to have to go to an emergency department that day.
Yeah.
So I think emergency physicians develop those particular people skills that I think we should be rightly proud of, but are also very adaptable to other environments.
Yes, yeah. No, that's really interesting, I think, because superficially, like I said, one thinks about just stitching people back together, but there's a lot more to it.
There's a little bit more to it than that, Barry, yes. And shamefully, it's been a while since I've stitched somebody back together, but that is a fun thing to do.
I can imagine, yes. But we digress, pardon me for that. London LPP, tell us a little bit about that, please.
So London Procurement Partnership was set up actually 20 years ago this year.
Okay.
And that was, I think people realise, hopefully, that actually we don't have one NHS. So we have a couple of hundred individual purchasing authorities.
Okay.
And it makes sense in terms of logistics and economy of scale to bring organizations together, and not only to bring more leverage to the market, but to rationalize the market. And what London Procurement Partnership does, along with several other NHS hubs and some private providers in England, is provide routes to market for NHS purchasing authorities to buy things effectively.
Excellent. And is LPP, is it growing in its involvement? Is it just helping hospitals do procurement in London, or what else?
So our base is in London, and we're a membership organisation, and the vast majority of our members are the London hospitals, but we work nationally. So we collaborate with some other hubs to enable our systems to be available to hospitals throughout England, but also we've been selected by central government, by the Department of Health and NHS England, to run national programmes, most recently in the frontline digitalisation programme. So that is bringing trusts across the country who are digitally naive or don't yet have an electronic patient record up to that level of digital maturity.
Excellent. Yes, that's quite a complicated space, isn't it? I've been reading a lot about the developments of the electronic patient record ecosystem, and I must admit I find it incredibly complicated and challenging to follow. Maybe we won't go down that road in this conversation. But,
for another conversation, perhaps.
Yes, of course. I think a lot of our listeners know that we had your colleague Lee Joseph in this conversation a little while back, and we talked a lot about the nuts and bolts of procurement and challenges in NHS procurement from several perspectives. But your role, Andrew, is much more medical and clinical and oriented with clinicians. Is that right? I'd love to hear a little bit more about that, please.
Yes, I certainly wouldn't describe myself as a procurement expert, and I'm sure my colleagues would agree with that. But one of my roles within LPP is to ensure that all of the work that we do is clinically assured, so that our members, the trusts that use our services, know that everything that is available through LPP is appropriate, safe, effective for patient care. So we may use, for example, generic public sector procurement regulations, but that may not specifically address the needs of all of the different potentially complex patient care requirements. You'll understand that mental health requirements may be very different from pediatric intensive care requirements, for example.
Yeah. And to me, that seems quite fundamental. Has that always been the case in LPP and in all procurement, having what's the word for it? The foundation of assessment of medical fit for purposeness.
Well, we call it clinical assurance.
Clinical assurance.
That's that umbrella term that demonstrates to our users and to the end user, to the clinician and the patient, that there is clinical assurance in oversight in everything that we deliver. And no, that's not the case generally. We are currently unique in providing that.
I'm intrigued. Perhaps this is quite a naive interpretation, but how could you buy anything if there isn't this level of clinical assurance established at the foundation level? What do procurement people do who aren't, like yourself, experts on the clinical side?
So I think with medical devices, which would of course be registered with the MHRA, that is done by a separate body. But if you're providing services, so digital solutions, non-emergency patient transport, for example, and other areas of care that may not necessarily immediately sound clinical, linen and laundry, for example. A provider of clean linen and laundry needs to understand what the infection prevention and control requirements of that are. It doesn't sound very exciting, but it's important.
Super important.
And needs in a hospital will differ from needs in a hotel, for example.
Okay. And where is this going in terms of the clinical assurance, what do you want to call it, layer of procurement? You mentioned that it's unique for LPP.
It is, but it can only increase, and that's because I think as a purchasing authority, and I've said already that there isn't one NHS, but if we,
Yeah,
well, maybe that's another conversation. But
yes,
as a purchasing authority, centrally, the government, the NHS, understands more the necessity to move towards value-based healthcare. So
yes,
that is value more than cost. And we inevitably need to understand better what we mean by value. And that tends to mean outcomes over price, to be honest. And so how on earth can we make that decision on what an outcome is and what value is without increasing clinical involvement and patient involvement in those decisions?
yes, yeah,
So I think most people would easily recognize the decision in, do you buy a slightly cheaper hip prosthesis, for example, but if it needs replacing in a shorter period of time than the more expensive, maybe longer lasting one, well,
yes,
is that genuinely value?
yes,
And there's not just a financial value to that decision. There's a patient impact, there's a service delivery impact. So I think most people would grasp that. The complexity that we deal with in healthcare is that patient pathways and care pathways often are much more complicated than a single episode of care, and
yes,
also cross over lots of organizations, and each organization is funded separately. Even within a trust or a hospital, there
that's
will
right.
be silos of funds, and so
Yeah.
that starts to get more complicated. And if we don't involve clinicians in understanding those decisions, then we're likely to make the wrong decisions.
No, that's helpful, and that clarifies things. It is complicated. It's extremely
Yes,
complicated.
but
And
that's
every
what
single,
makes it fun.
well, every conversation we have just highlights how more complicated it is than I understood previously. But this clinical assurance, are you involved, Andrew, or not necessarily in the what's the word for it, in the applications of this clinical assurance with regard to discussions with suppliers? Is that an area that we could explore, or is that not really your area personally?
So how we manage it currently is through assurance in our framework. So our routes to market are clinically assured. So
Yeah.
that means that suppliers that apply to go onto those frameworks and so are within the marketplace from which trusts can purchase must satisfy certain criteria to achieve that.
Yes. Andrew, what I'm curious to learn about, if it's relevant for you, if not, we can look at other issues, and that is from the supplier's perspective. The clinical assurance is part of their application to do business with the trust. Is that right?
So yes, we would expect that suppliers have an insight and an appropriate product that would achieve clinical assurance.
Yeah.
So it is not so, and many will already because they have been active in this field anyway. But yes, it is our kite mark, if you will,
Okay.
to demonstrate that yes, this supplier has achieved the threshold or the requirements
Excellent.
to be clinically appropriate.
Okay. No, that's very helpful. And how does this type of approach get rolled out nationally? Is there a movement to expand this beyond the expertise?
Well, I'm
of the
certainly
office?
hoping to drive that movement. Yes, of course, because as I say, it is not standard,
No.
and which I'm sure will come as a surprise to many. But it is it is our LPP's unique selling point, but it absolutely shouldn't be.
Yes. Yeah. So what does that mean? I mean, are there programs in place to roll this out nationally? Are there training programs? Are there procurement accreditation discussions where one day in the glorious future, everybody working in procurement across the country will be applying these kinds of systems? Or
there are already clinicians working in procurement, and there are clinical procurement professionals working in hubs, in trusts across the country.
okay.
What we're doing is adding a senior layer to that, and particularly in the activity of LPP, which is not in medical devices per se, but
Right.
in everything but. So in, as I said earlier, digital solutions, estates, facilities, workforce. We are active in pharmacy, in some medicines optimization, but in pharmacy procurement.
Oh, okay.
But our and I think it's important for us and for our customers, our end users, to appreciate the fact that although these things may not immediately feel clinical, it's not a device necessarily.
It's not a scalpel or something.
Right.
Yeah.
But very obviously, to a clinician, to anyone working in the health service, all of these things have an impact in patient care, in patient experience, in how clinicians work and interact, in productivity, in efficiency. And the NHS is currently all about efficiency, productivity, and savings. And
Absolutely.
so that's, I think the potential danger is that we make decisions based on cost and availability and alone, and there's a risk, therefore, that we make closest fit rather than best fit that may not be applicable in a clinical setting.
Yes. Yes, that's very interesting. I mean, there's almost, in my mind, a permanent tension between cost and value. Maybe that's too simplistic of an interpretation, but
no, I think that's entirely valid, and there are a couple of reasons for that. I think value is quite hard to define.
Absolutely.
Because we use it as, if we use the classic equation of it's outcome over cost, well, how are we defining outcome?
Yeah.
And some outcomes are reasonably binary, but even those may change with perspective, with how the patient is experiencing that, and they certainly change over time. So if we struggle to define outcome, then it's very difficult to then ascribe value. But also, we live in a world that financially runs from April to April, and if we're looking at whole patient pathway cost and so value, then patients and clinicians don't tend to work April to April. And not only do we have, time to produce a return on investment, maybe longer than a year, but also, as I said earlier, we have patient pathways that may cross lots of departments or even lots of organizations. And if an innovation, a process, or a device is purchased by one organization, but the return on investment or the improvement in care or the outcome is realized elsewhere,
yes,
then we have not necessarily an incentive for that original purchase. So we have to be much more clever about how we distribute resource how we buy things, how we pay for things.
Yes. Now it's even more complicated than I thought. And what
Maybe
you
this
just
will have to be a series, Barry.
maybe we have to allocate a few more hours to cover this topic. What are you doing next week? No. Pardon me for joking about this, but it's fascinating, the different organizations and the fact that those are different budgets, right? Different decision makers, different priorities, different physical locations, but all overlapping a single patient. Is that right? And therefore,
Absolutely right.
the measurement of the outcome over the cost becomes even more complicated.
Correct.
Yes, we need AI to solve this. The way I'm looking at it now. So no, I'm kidding, but I'm joking about how incredibly
I
complicated
thought
this is.
AI was the answer to everything, wasn't it?
So is that something you're involved in or not? This view of the multiple organizations involved in the outcome equation and the attempts to reconcile the measurement of that, or not really?
It's not something that I'm directly involved in. It's something certainly that I am interested in. And I think all
Yes.
clinicians in management and leadership roles should, if they aren't already, be appreciating this, because it is an additional complexity that
Yes.
is it's a problem that we have to solve, because at the
Mhm.
moment we are making fairly short-term decisions based on immediate need and a lack of appreciation or understanding for long-term value.
Yes.
But we can't afford to keep doing that.
No, exactly. And therefore, it could literally directly cost less to look at this from the longer term value
Of course.
perspective.
Yeah, exactly.
Yeah.
And I think, another maybe slightly silly example that I use is that, finance to me is this: we all manage our own domestic finances. So why, when we go to work, we seem to forget all of those
The basics.
ways of thinking is bizarre to me, but there we go.
Yeah.
But we can
Yeah.
understand that if we need a kettle, we can buy a cheap kettle today and it may last a year, and then we have to go out and buy another one. Or we can invest in a rather more expensive kettle and maybe it'll last us 6 or 7 years.
Yeah.
And I think most people can make that kind of judgment. But if you are already in debt, you cannot contemplate the more expensive kettle. You can only buy the cheap one. And it feels like with the NHS that because we are almost always, if not in debt, terribly worried about spending money.
Absolutely.
And terribly worried about justifying longer term investment. There are conversations, there is movement towards multi-year funding and a slightly more long-term view of investment in larger projects, in estates, buildings, infrastructure. And I think that, and that makes sense. And I'm hopeful that that will filter down, because certainly if we are serious about using money, taxpayer money, using resource more cleverly to make better long-term decisions and purchases, then we absolutely have to.
Absolutely. Yeah, no, that resonates very strongly. Well, look, this is an absolutely fascinating topic. I would, joking aside, love to consider exploring it further, perhaps in a follow-up call, and perhaps you could consider any of your colleagues that would like to join that call. Going back to your role in LPP, is there any particular overlap actually with suppliers, or is your role quite separate from the relationship between LPP and businesses supplying hospitals?
No, I absolutely talk to suppliers all of the time. I think that we have an obligation to make it easy for ultimately for patients to get the best products. So there is a world of great ideas, products, services, innovations. There are 67 million people in the UK who potentially at some point in their lives would benefit from that.
Absolutely.
And we have as we have mentioned a couple of times on this call, rather complex system of bringing the two together. So anything that I can do that helps suppliers to navigate the complexities of the NHS to benefit patients has got to be a good thing. And I'm actually in a very fortunate position to be doing that overseas as well. So we do some work with the UK government, both with the Foreign Commonwealth and Development Office and the Department of Business and Trade, in looking for organizations overseas that either are put off by selling into the NHS for all of the reasons that, we're talking about, or don't understand how to navigate it, but would, but are interested. And that's an extra dimension to what we're doing with through LPP.
Oh, fantastic. No, I wasn't aware of that, the internationality aspect of it. That's extremely interesting.
It's a small aspect, but it's
interesting and worthwhile. We're going to wrap up in a few minutes, if that's okay, Andrew, but this has been incredibly valuable and interesting conversation. In summary, continuing on the topic of suppliers and the complexity of the NHS, would you offer any, if this isn't too simplistic of a question, any advice or guidance or suggestions regarding the challenges suppliers have applying to the NHS, or any tips or any general views you want to give to suppliers who want to engage successfully?
Wow, what a huge question to end in the last couple of minutes. But of course, yes. So I mentioned earlier, the NHS at the moment is all about savings and productivity. We are employing more clinical staff since the pandemic than beforehand, and yet patient activity and throughput is down. And I don't think anyone really understands why that is. I'm sure it's multifactorial, but we must be able to do more with the resource that we have.
Yes.
And that means being cleverer with what we purchase, how we purchase it, and with our suppliers providing us with innovative and cost-saving or productivity increasing solutions. So suppliers really need to be able to articulate that. And I think the key is to be able to articulate their benefit to the right person. And that's a complex, and that's, again, that's going to be another conversation, Barry, because, identifying the key opinion leader or the person who holds the pen on a procurement decision within the trust can be very difficult. And that's certainly something that suppliers need to identify early on, because I think because you are not selling to the NHS, you are selling to each individual organization, and that is exhausting.
Exactly.
But you have a fantastic organization. You have a national pool of data and patients. It is an extremely valuable market. And the NHS is genuinely open to new ideas, to innovation, to trialing, to piloting things, and is seen internationally in that sphere, so that suppliers that supply into the NHS can wear that as a badge of pride across the rest of the world.
No, absolutely. And I've heard that on many occasions, that if a supplier says, well, look, we are a approved supplier, so to speak, to the NHS, that's quite a badge of credibility and accomplishment internationally. No, but that's very helpful, Andrew. I know we're kind of circling around the same subject, but the complexity of the NHS, how do you say it, the dispersity of it, the hundreds of different organizations as opposed to one person in the Department of Health whose job is to buy that one thing from that one supplier and things like that. This is genuinely practical, helpful guidance, I think, for a lot of our listeners, and also inspiring about the size of opportunity and the benefits. So that's worthwhile.
Well, very much so. Yeah, and hopefully it will inspire further conversations.
Absolutely. Well, Andrew, thank you very much. I hope we haven't taken up too much of your valuable time today, but this has been extremely interesting. I've learned a lot, and we're grateful for you sharing all of this useful information.
It's been an absolute pleasure, Barry.
Thanks once again. This is Andrew Stradling joining today's episode of Selling to the NHS. I'm Barry Shrier. We hope you find these videos interesting, and if you do, please like and subscribe to the videos. And we also invite people to apply to join these conversations, so don't hesitate to contact us directly. You can find all the contact details at the bottom of this video. Thank you once again.